I'd like to put this series on innovation into perspective. Here at Johns Hopkins, we have a history and a culture of innovation and discovery. We have long pushed the boundaries of what is known. Here, assumptions are routinely questioned, ideas are debated, and new knowledge is created and shaped. It is this culture of innovation that I hope this year's lecture series will help to support and to celebrate. By featuring some of our most innovative faculty, we seek to highlight what I believe is a unique role of research universities in fostering innovative thinking, creative solutions to some of the world's greatest challenges, and furthering the knowledge that all of us are here to advance. Innovation is happening every day and in many different ways, and inventions and discoveries are certainly not the exclusive domain of academia. In fact, many have argued that the academic culture no longer is the best environment for out-of-the-box thinking. During this year, however, our series will highlight how Hopkins faculty are taking on very important problems that have eluded the most clever and disciplined of minds. Indeed, in my own first year as department chair, I was confronted with two situations that seemed out of character with the exceptional capabilities and systems that we have here at Johns Hopkins. It was a Sunday afternoon in 2004 when I received a call. A 12-year-old boy had been hit by a car and was taken to the emergency room at Johns Hopkins Hospital. He suffered head injuries and facial fractures and was having difficulty breathing. In preparation for intubation to ensure the safety of his airway, the emergency team induced sedation and paralysis. With other physicians unable to place a breathing tube, one of my junior residents was charged with securing the obstructed airway. The resident, only months on the job, could not successfully place the breathing tube. There was no one else to turn to. The attending pediatric surgeon was on the wards. The attending trauma surgeon was in the operating room. Time ran out, and the young boy died. Fast forward then 6 months later to another Sunday afternoon in Baltimore and another call. A 34-year-old man with leukemia was in the intensive care unit at Johns Hopkins Hospital with an upper GI bleed and multiple organ failure. Once again, one of my residents working with a resident in anesthesiology was unable to secure the airway and unable to get help in time, and this man also died. Now, as my department confronted these tragedies, we could have rationalized what had happened. We could have comforted ourselves that these patients were both very, very ill and might well have had poor outcomes no matter what we did. Instead, we admitted our mistakes and we started the process of examining and then changing the system and the culture that had allowed these mistakes to occur. That journey began when I sat down with family members to explain what had happened, to express my profound sorrow and regret, and to admit to them that the death of their loved one was the result of human error and of our systems being insufficient to prevent such errors. But changing the culture would not be easy. Like many faculty members, the entrepreneurial spirit of this place is what brought me here, and it's what keeps me here. But sometimes our emphasis on individual achievement can divide us into silos and make us resistant to change, suspicious of collective initiatives, and without necessary checks and balances. As my department set about working with other departments to examine our systems and change our culture, we were fortunate that the culture of change had already begun here at Johns Hopkins. Following two high-profile and tragic medical errors, Johns Hopkins Medicine set a goal in 2002 of making its care the safest in the world. At the forefront of these efforts was and is Dr. Peter Pronovost. Now, I'd like to end with just another story. This one begins in 1935. That was the year that Boeing demonstrated the prototype for its B-17 bomber to the United States Army Air Corps. The B-17 could carry 5 times as many bombs as the Army had requested and could fly faster and almost twice as fast as other bombers. But on an October morning at Wright Airfield in Dayton, Ohio, with the military brass looking on, the aircraft stalled soon after takeoff and crashed in a fiery explosion. An investigation revealed that the pilot forgot to release the elevator lock before the flight. Newspapers called the B-17 too much of an airplane for one person to fly. Boeing nearly went bankrupt, but the company and the B-17 were saved when they created a pilot's checklist for takeoff, flight, landing, and taxiing. Pilots went on to fly the B-17 for more than 1.8 million miles without a mishap. The Army ordered 13,000 B-17s, giving the United States a decisive air advantage in World War II. The revolution in patient safety here at Johns Hopkins also began with a humble checklist for preventing central line infections, and that checklist was developed and implemented and nurtured by Dr. Pronovost. It was, in a sense, an incredibly simple innovation, but one that had tremendous impact. In Michigan ICUs, the checklist decreased the rate of central line infections by 66%, virtually eliminating these deadly infections. Devising the checklist, as it turns out, was the easy part. In trying to get providers to actually use the checklist, Dr. Pronovost faced an institutional and physician culture that was at times resistant to standardization, central accountability, and teamwork, all of which were a necessary part of the change in culture. But slowly and persistently, Dr. Pronovost has helped lead change here at Hopkins and in hospitals around the world. And it all began with a checklist. Now, since those dark days in 2004 and the multidisciplinary airway team that followed our efforts and our investigations, there have been no more lives lost because of mishaps in securing an airway at the Johns Hopkins Hospital. And I want to thank Peter for helping to pave the way for that. Now it's a privilege to invite Dean Nick Jones to come to the podium to introduce Dr. Pronovost. Nick?
Thank you, Provost Minor. It is my pleasure to have the opportunity to introduce Peter Pronovost to you. Peter is a professor at the Johns Hopkins University School of Medicine in the departments of anesthesiology and critical care medicine and surgery, a professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health, and is medical director for the Center of Innovation in Quality Patient Care. He received, native of Connecticut, he received his bachelor's degree from Fairfield University and his MD from the Johns Hopkins School of Medicine, his PhD from the Johns Hopkins Bloomberg School of Public Health. As you heard from the Provost, Professor Pronovost started studying hospital-acquired infections in 2001, concluding that a simple 5-item checklist protocol would greatly reduce infections when inserting a central venous catheter. As the Provost also indicated, in Michigan alone, in the first 3 months of a demonstration project, the infection rate decreased by 66%, as you've heard. And in the first 18 months, they estimated that 1,500 lives and $100 million were saved by this simple intervention. These results were sustained for almost a 4-year period, which is just incredible. In 2008, Time magazine named Professor Pronovost one of the 100 most influential people in the world, and that same year he was awarded a MacArthur Fellowship, otherwise known as the Genius Grant. He has a book, Safe Patients, Smart Hospitals, How One Doctor's Checklist Can Help Us Change Healthcare from the Inside Out, that was released in February 2010. There's a very nice quote that I will end with, attributable to Professor Pronovost. I won't read the full quote. I'm just going to pick a couple of pieces out of it and then finish with a point. And it begins, "The fundamental problem with the quality of American medicine is that we have failed to view the delivery of healthcare as a science. That's a mistake, a huge mistake. Sounds like he's an engineer to me. Peter, welcome.
Thank you very much, Provost Minor and Dean Jones, for having me here. I guess we'll know we'll make progress when I have engineering as another one of my joint appointments. I want to share with you a story of how we accomplished that work and then broaden the scope of how it might apply to the work we do in medicine and public health. But I want to begin with this notion of humility, because it's an attribute or a value that is unfortunately too rare in medicine, and it's an attribute which, if we don't have it, I don't fear we're going to make progress in healthcare. I, for good or for bad, happen to be easily and often humbled. A few months ago, I was giving a talk after being on call in the ICU, and I left the ICU at about 6 in the morning and looked like I'd been on call. And I get off the plane, and I was running late, and they had a distinguished-looking gentleman with a tuxedo on with a sign that says Dr. Pronovost. And I said, okay, come on, buddy, let's go. I'm going to be late. And he said, oh, no, Sonny. I'm waiting for a famous Johns Hopkins doctor. I said, okay, could I at least go for a ride? Now, in 1947, on a cool October night, Ludwig Wittgenstein and Karl Popper were sitting having a glass of wine at the Cambridge Moral Philosophy Club. And they got into a heated debate. Popper criticized Wittgenstein for encouraging students to only solve puzzles. Wittgenstein, if you may know, was quite clear that applied work was useless, that we only should do puzzle solving. Popper essentially said he was destroying a decade of scientists, and Wittgenstein got so angry that he picked up a poker in the fireplace and chased him out of the Cambridge Club. And that story was recounted in a book called Wittgenstein's Poker. But that debate continues today in American medicine. There's this huge tension between, do we solve puzzles only, or do we solve problems? Let me share with you an example of how that played out in a patient I was caring for. I was making rounds in the intensive care unit, and a young woman who was a mother of a 3-year-old had just given birth to another child. She had Marfan's disease, and she ruptured her aorta after she delivered. She had been in the hospital for months and actually had 3 subsequent operations. And as I was rounding on her, she grabbed my hand and said, "Don't let me die." And she had, any of you who are clinicians, she had that look that sick patients know deep in their soul that they're in extremis, that something horribly wrong is going on. And within about 5 seconds, she arrested. We quickly got an ultrasound probe to see if she was bleeding into her chest or from her aorta. There was no bleeding in her chest, so we whisked her off to the operating room where the surgeons went to work. And as I was walking back from the operating room, I ran into her husband. And her husband told me a story that is the history of American medicine, in many ways the history of Johns Hopkins. You see, he told me that his father dropped dead at the age of 34 from what most likely was Marfan's disease, but we didn't know it was a disease at the time. His older brother had surgery at Hopkins for Marfan's disease, but died on the table. He had surgery for Marfan's disease, but survived. The mortality from this operation was improved dramatically from surgeons like Dr. Gott. His daughter then had a genetic test to identify the Marfan's gene, again developed by Dr. Dietz at Hopkins, had serial ultrasounds, and was on drug therapy that was identified by a randomized clinical trial that prevents the aortic dilatation. All amazing problem solving discovered at Hopkins. And yet, his daughter was dying. She wasn't dying because we didn't tie knots right. His daughter was dying because her first surgery got infected, and it makes the tissues weak, and her aorta ruptured now for the 3rd time. Luckily, she survived, but his story was just so emblematic of what we've done in American medicine. 120 years ago, Johns Hopkins was founded with this vision of linking an academic medicine or medical school with the hospital. And our leaders brought their keen intellect and direct powers of observation, and they studied mostly physiology in what at the time would be considered basic science. And we were amazingly successful at that. And then in the mid-90s, we realized, well, we have a whole bunch of understanding of basic physiology, but we don't really have people qualified to do clinical trials to study them. Indeed, clinical trials at the time, even when I was in medical school, was kind of you do that on the side. You dabble. Real scientists are basic scientists. And I'm a product of those investments in clinical investigation. I think Provost Minor was one of the instrumental people in creating a clinical investigation program, so we trained physicians to know how to do these in a robust way. And now, as you may know, 18,000 clinical trials are published a year. And yet, we're killing people from infections still. And in part, I think, is because we haven't yet applied science to that last piece of healthcare delivery. We too often believe the end game of biomedical research is new knowledge. We publish it in a high-impact journal, we get our grants, and we clap our hands. And we need to start viewing that health, not just new knowledge, is the end game. And the need to do that could not be more urgent. We don't really know how many people die needlessly from infections, but let me share with you some of what we do know. We know 100,000 people die from infections each year. We know 100,000 people die from DVTs and blood clots, most of which are preventable. We know scores of thousands die from teamwork failures. Scores of thousands die from not getting the right evidence-based practices. Add them up, and you're somewhere around the third leading cause of death for a problem that most medical schools don't even have the technical experts like that exist in our engineering or business schools to study. Right? It's a travesty that we need to make a difference. And besides that human toll, there's an even bigger sociological input or societal input that the public now is questioning the value they get from academic medicine. I mean, our funding for graduate medical education is under attack, and much of the public is saying, what am I buying for this big investments? And in part, they have every right to question it because we haven't focused on solving problems to the extent that we need to. I want to share with you a story of how we tried to do that. And it's a story that is an interdisciplinary story. And if I think about what guided us there, I'm reminded of this quote from Rusty Shumpter. Rusty was an astronaut in a pre-lunar Apollo mission and was interviewed after flying over the Middle East, I think it was the first time, about what the Middle East looks like from outer space. Right? His words are so poignant, given what's going on in the Middle East now. And Rusty said, what I noticed is that there's no lines in outer space. We invent them. They're figments of our imagination. And yet on Earth, we kill people over those imaginary lines. Right? And if I were to think about the field of quality, you can say perhaps the field of medicine in general, over the last decade, I see a whole lot of lines. See lines at the federal level where we don't have clear goals and disconnected. Lines at the state level where a variety of different agencies are telling us to do often contradictory things. And lines within our universities where we don't draw on the richness and the great expertise that we have here. So this story that I'll tell you is about reducing those lines. Now, let me share with you the typical approach to patient safety and quality. These are slides that our surgeons will recognize of wrong site surgery. Now, the scientists, since we're a research university in the audience, might conclude that our national efforts are doing one heck of a job at causing wrong site surgery. Boy, we are really doing a good job making those errors go up, right? And I don't think that's the case. But I do know that we made national policy with an incredibly superficial understanding of the problem. There was no real good theory that guided us. We made national policy with no pilot testing if it worked. And we made national policy with absolutely no measurement system. So this is likely just reporting bias, but we really don't know, and we certainly haven't solved the problem, and we need to be guided by science if we're going to do this. Now, I wish I can say that my interest in this field began nobly, but I can't. It began, as Provost Minor told you one of the stories, because this little girl died at our hospital. She died of a catheter infection. And her mother came back and said, Peter, could you tell us that Josie's less likely to die now than she was a year ago? And I started talking to her and telling her all the stuff that we're doing. And as I'm talking, I must have seemed like I was playing whack-a-mole because there was no theory, there was no strategy, there was no measurement. And I finally just had to say, Sorrel, I can't. You deserve an answer, but I can't tell you that she's safer. At the time, our infection rates in all of our ICUs were outrageously high. To give you an idea of what I mean by outrageously high, they were 11 to 15 per thousand catheter days. But to say what I mean by that, if a hospital had that rate of infection now, I would say publicly they deserve to be shut down. I mean, it is such an egregious lapse of safety standards. But at the time, I was one of those doctors causing infections. And I knew I didn't want to hurt people, but I was. I thought these infections were inevitable. I'm trained as knowing all the evidence-based practice, and this delivery stuff, well, that just happens. I'm not really accountable for that. So we questioned that. And I went to the Centers for Disease Control guideline, a guideline that's scholarly, a guideline that's elegant, and a guideline that's near useless for me at the bedside, because it recommends 90 things. It's 200 pages long. And any of you who are clinical know I'm lucky if I can do 3 things, let alone 90 things, right? And it doesn't prioritize what's most important, it just throws out 90 things to do. So we had this insight, not so novel insight, to use a checklist. Now, checklists aren't new. My mother uses them to go to the grocery store. My kid uses them to keep track of their homework. I think perhaps because of the lack of humility, we haven't applied them in medicine, because if you're not humble, you don't need cognitive aids, or you remember anything. So we went to that guideline and called out 5 simple items on it. Wash your hands. Clean your skin with chlorhexidine. Avoid the femoral site. Cover yourself and the patient, and ask every day if I still needed these things, if I still need the catheter. Now, we looked, and I was doing those things, our team was doing those things 30% of the time, 30%. Now, I could have just said try harder like our typical approach, but we borrowed some of the techniques that we learn in our business school and our engineering school to try to understand what I call the science of safety. So we walked the process. We interviewed people. We observed clinicians what they had to do, and I had to go to 8 different places to get all the equipment needed to comply with that checklist. Caps were in one place, masks were in another, gowns were in another. Half the time they weren't stocked, and when they weren't stocked, I made what in my brain was a rational economic decision. I said, is it worth me spending 10 minutes running down the hall to get the supplies, which means 10 minutes I'm not going to spend caring for another patient, or do I just go without it? And go without it, the infection might not happen, and it's invisible, and it's not my fault anyways. It's an act of God. So clinicians routinely would say, I'll go without it, right? Not because we're have any malintent. We want dearly what's right for the patient, but we had a bad system. So we got a line cart, assigned someone to stock it, took 8 steps down to 1. Compliance with the checklist went up from 30% to 75%. Infection rates went down from 11 to 5. Good, but still not good enough. So I pulled the doctors and nurses together and said, nurses, I'd like you to work with our doctors when they put this checklist in. And if they don't comply with it, you're empowered to stop takeoff. That is, you can make them go back and fix the defect. And folks, I literally caused World War III in the hospital. It was when I clearly realized that if we don't take efforts to address culture, we only apply it as an engineering thing, we're not going to make progress. The nurses said, there is no way I'm going to question a doctor, because if I do, I'll get my head bit off and it's not my job. The doctor said, Peter, you can't have a nurse question me in public. It makes me look like I don't know something, right? What was striking is there was no debate about whether we should do this, right? There was no questioning of the evidence. It was culture and ego and hierarchy. So I pulled the group together and said, is it tenable that we knowingly harm patients here at Johns Hopkins? Everyone says, of course not, Peter. And I said, and doctors, do we agree that this checklist is evidence-based that we should be using in all patients. Of course, Peter, yes, it's from the CDC. We should be doing this all the time. So then, okay, well then our egos can't get in the way of this. So we have permission, we're human, to forget to wash our hands. We have permission to not remember to wear a cap. But we don't have permission to needlessly put a patient at risk. So if you forget, it's okay, you're human, but if the nurse sees you, she's going to question you or he'll question you, and you're going to go back and fix the defect. And nurses, I know you're afraid of getting your head bit off, so let me be clear. If the docs give you flack, please page me any time of day or night. You will be supported. Physicians, if we disagree with the evidence, let's have a conversation about what the evidence should be. But you just told me you agreed with it, so we're not going to have ego get in the way from it. I wasn't paged. Compliance went up to 98%. Infection rates went down to 2. Right? Unheard of performance. No one thought this was possible. Matter of fact, when we began, the doc said, Peter, what are you wasting your time for? We take care of sick patients. We're at Johns Hopkins. All these infections are inevitable. So we then applied further science of safety by starting investigating every infection as a defect. That not only changed our mindset that from they're inevitable to they're preventable, but we found things. Like we found half of our infections weren't from catheters placed in the ICU. They were placed in the operating room or the emergency department, and we hadn't brought the program there. So we went there with evidence and said, put the program in. Infection rates went down to 1. We then investigated further and found the remaining infections that we had were from people who had catheters for a long time. In other words, it had nothing to do with how we inserted the catheter, but it had to do with how the nurses were using the catheter every day. And so we looked, and what did we find? No standard process, wide variation in knowledge, no feedback or audit of performance. So we tightened up those processes, and infections were eliminated. Now, to frame this for you so you have a context for it, these bloodstream infections kill as many people each year as prostate cancer, about 33,000, just slightly less than the number of people that die from breast cancer. And I then got a phone call from the Michigan Hospital Association who said, Peter, we're doing this program and we want to do something about safety. We've read your work. Would you work with us to go do this? And to be honest, I was still in I'm a scientist. I solve puzzles. I don't solve problems, right? I'm not a consultant. I don't do this work. I'm an academic doc. What are you calling me for? They said, yeah, but you solved a problem. And we'd like you to share that knowledge with us. And I said, well, it is a problem the size of breast cancer, so I fought this moral tension. I said, well, there's an application for a grant from the federal government. Why don't I apply for it? If we get it, that'll cover our costs, and we'll go do it. So we applied, we got funded, and we put this program in. And as you heard, we, within 3 months, cut infections in half. Within 6 months, they were reduced by over 66%. The median was 0, and now they sustain 0. Remarkable improvement. We also measured culture. This was one of the first times, or actually it is the first time in any industry on a large scale that an intervention has been shown to move a safety culture. This culture is measured by a survey that you give clinicians. We do it in our hospital. It's one of a handful of validated culture surveys. But perhaps most importantly is we moved mortality in a whole state. So let me tell you this. We did what I was calling strategic research. So we knocked the socks off these infections, and we were thinking now, could we scale this program nationally? But I knew I had to get some buy-in from different stakeholders. And many people were saying, even though the infections were great job, Peter, but did you really save lives? And so we had to study it. So it was actually one of our doctoral students in health policy and management. This was her thesis with us, where we looked and said, okay, well, let's look at the mortality of any Medicare patient admitted to a Michigan ICU. And we were intentionally conservative to say anyone in the whole state, because if this is a policy level intervention, some hospitals may not sign up. So those of you who are clinical researchers, you'll know it's like an intention to treat analysis. And we compared that to similar patients in the 11 surrounding states. And what you can see is the mortality in Michigan ICU patients was the same before intervention. The two curves start to splay when we started, and amazingly, they're still splaying now. But the bottom line is a Medicare patient admitted to Michigan has a 10% lower risk of dying than a similar patient in the 11 surrounding states. I mean, remarkable impact on mortality. We also published with a health economist from Bloomberg showing that the average hospital saved about $1.5 million and this insurer saves somewhere around $200 million a year. So we're aimed with this data now, and we said, okay, could we scale this across the country? So I knew I needed to replicate it in one other state because, again, the naysayers were saying Michigan's a fluke, middle of America, they're all friendly, this could work there, this had to work there. So we shopped around, and we had to try to get some philanthropic funding, and Rhode Island agreed to do it. Interestingly, Maryland was early on the list to do it, but at the time, quality improvement researchers didn't collect rigorous data. So Maryland said, well, and so did New Jersey, well, we'll do it, but, Peter, we don't like this standardized data collection stuff. Just let everybody do it their own way, and that's the way we're going to do it. And I'll never forget this. New Jersey was the first one to do it in a non-standard way, and my gut said it's wrong, but they were very experienced, and they're working with a very seasoned quality improvement group that's nationally recognized. And I said, okay, whatever, your experience, I'll go ahead and go with this. And we did the project, and they called a press conference to say, look, we replicated Michigan results. And I was analyzing the data, and I made a spreadsheet. And if you can figure that spreadsheet, very simple spreadsheet, where rows are individual hospitals and columns were time periods. And I made each cell that was missing data red. And it lit up like a stop sign. And what I showed was that the hospitals who submitted data before the intervention were not the same ones who submitted data after the intervention. So you may have improved, but it was a myth. I certainly couldn't make any strong statements. And it was one of the most morally wrenching moments I had in my life because the TV was there, the newspaper was there. And I told them, I said, I know you want me to go say you improved, but I can't. I can say I don't know if you improved. I can say your citizens deserve better data collection, but I'm not going to say you improved. Scientifically, I can't say it. It would be scientific misconduct. And so I stood on stage, had one slide with a stop sign, and basically said, I think your citizens deserve better. We then came to Maryland. Maryland was working with the same national group. Peter, we don't want standardized data collection. Let everybody do it their own way. And I said, not making that mistake that day, I owe that little girl's mother an answer. I can't give her one without data. So I'm sorry, and we terminated our contract. And again, not an easy thing to do. We have relationships with Maryland. Rhode Island then said, okay, Peter, we'll do it. We'll collect data in a standard way, published it, exact same results, eliminated it in the whole state. So it got the attention now of Congress, of policymakers, and we're funded by AHRQ to put this program in state by state across the country. It almost killed me how much time it took. And what we would do is we go into a state, we'd partner with the health department, the hospital association, and the quality improvement organization. Most of those groups never talked to each other. They didn't even know each other, yet they were all working on infections. So we would bring them together, align their efforts. We recruit hospitals, and we've now, across the country, reduced these infections by 66%. I mean, unheard of performance across the U.S. And the model that we developed, again, I'm going back to our engineering, you could think of this model as a fractal, because what we realized is that you need infrastructure at many levels. So a fractal, like a fern, as you probably know, is a geometric shape that has the same shape but varying sizes, but they're all part of an integrated whole, right? And what we created was a national infrastructure for quality and safety, working with CDC, working with CMS and ARC, state infrastructure, and then infrastructure within a hospital. And as we did this, we, what I call, pulled on multiple levers. So to drive this change, we not only had communities of clinicians guiding us, but we worked with the employers to say, hey, you ought to create economic incentives. We know we can do this. Make these rates public. So we created social pressures, economic incentives, and worked with regulatory agencies to make these efforts part of a national safety goal. So I think all of those efforts combined allowed us to get this national 66% reduction. Now, I want to just make sure that we're clear that this gets branded as a checklist, but as our sociologists and anthropologists well know, this is a much more complex social technological intervention. And you could think of it as having three legs of the stool. The first leg is robust measurement of infections. The second leg is a program to change culture that we call CUSP. But what we realized is that when you look within healthcare organizations, or really any business, culture varies widely within the units. So the neuro ICU has a very different culture than labor and delivery, than the emergency department. And that unit level team has to own the work. I can't own it. They have to own it. But we need resources there to help them drive improvement. And they have to focus on what they see as their unique risks. And the third leg of the stool was a model to put evidence into practice, a model that starts with the checklist of what we should do, because one of the main reasons clinicians don't comply with guidelines is ambiguity. And any of you clinicians, you know, I ask you to read any one of your policies and procedures and see if you walk away from it answering who's supposed to do what, where, when, and how. Right? We're very ambiguous. Again, unlike engineering or other disciplines where they're very clear. We then assume clinicians want to do the right thing and find the barriers to their work, and then work with them to help change their systems. Now, the good news is this is the first national success story of nationally reducing a harm. The concerning news is that outside of these infections in ICU patients, every other infection is either flat or going up. So what we've shown is that we have a model, but it needs to be spread. Now, what we've done now is we've taken this model, again, in the whole state of Michigan, same results for ventilator-associated pneumonia. We picked this one because it's the second most lethal infection. It, again, kills just slightly the number of people of prostate cancer. We just got a large grant to do the same thing as we did for bloodstream infections, to roll it out nationally. We're starting, or we have started, in 10 states initially, and then it'll be scaled across the country. But I want to reflect on why this worked and why it likely could only work at a place like Johns Hopkins. Because first and foremost, we were guided by science. And I mean science at many levels. Right? Yes, there was biologic sciences of what is the evidence about a soap that cleans the skin, or the pathogenesis of these infections. And clinical research studies, but also human factors and systems engineers who helped us really examine the workplace, and business process improvement, and psychologists looking at how do you change team and cultures, and sociologists of how do you organize this huge complex thing and drive change, right? And it's because we drew on experts from all of those areas that we were able to create this really complex integrated change model that worked, because any one of them alone might move the needle a little bit. Together, we could move the needle across the country. We had a really clear theory of change, that we had an understanding of how things work. Now, for those of you who do basic or clinical research, you wouldn't think of doing a study without a clear grounding in physiology or pharmacology, right? Think about drug development, right? We have phase 1, 2, and 3 studies, and there's a lot of good theory and basic science research, and we always monitor for toxicities. If you look about how quality improvement programs are done in healthcare, they're shooting from the hip. No theory, no science, just go do it. Like I opened with the wrong site surgery. Just go do this across the country. No measurement, no monitoring of toxicities, and it's no wonder why they didn't really work, right? Because they weren't really grounded in good theory, and we need to do this. We kept score with the measure clinicians believe are valid. So much of our measures that we have are developed by regulators or administrators that clinicians just don't resonate with, and they're right not to, and they push back against it. I think the pushing back is right. What I hope we see is more leadership to say, but we will make them better. We'll develop measures that lead, and I hope academic medicine takes that challenge, and rather than being passive in this, is the one leading it, because I don't believe it'll work if the change is driven externally, because the solutions won't be wise. It has to be driven by this clinical community. We modify to fit local context. I get asked all the time, Peter, could I see the Michigan checklist? And I laugh and I say, well, there were 103 hospitals in it. There's 103 checklists, right? And when I first did it, my clinical research colleagues went crazy. Peter, you're destroying our ability to publish this paper. How are we ever going to be able to get this published if everyone's doing their own thing? And I said, yeah, I know, but if you standardize it, you're going to destroy it. Now, the reality is they were all 99% the same, but that 1% made it work in their place. And every one of them believed theirs was the best. They all were improving upon it, and it was the best for their context. Right? It fit their work systems, and they had to have that pride and local ownership. I couldn't do that. We framed this as a social intervention that was capable of being solved. And that is perhaps, as my sociology colleagues taught us, was really the key thing. You see, before this work, the attitude of clinicians was stuff happens. I don't mean to cause harm, but hey, these infections are in the inevitable bucket. And what we reframe that to say, no, they're not only preventable, but you have the ability to prevent them. You are able to do this. And once they believe that, they solve the problem. And finally, we created these clinical communities. And I want to take a minute talking about clinical communities because they are, I think, a breathtaking way of approaching this. Now, in solving these problems, there's overwhelming data from social science literature that things that are done to professionals, that is external controls, top-down approaches, are highly ineffective and often wrong. But things that are done with the professional group, by them, they're creating it, are much more likely to be effective, they're wiser, and they're much more likely to be actually implemented in their local context because people created them. But that is not what happens usually in medicine. We often come into a group and say, you will do this problem. You have a problem with infections, fix this. We didn't. We created a community, and they get their strength from each of the members because they bring this collective wisdom to them. We had a clear theory of change. Now, we also provided a lot of resources, but I'm not being Pollyannish to think these communities are self-organizing. They need to have support from what I call a vertical core who has the methodological and technical experts. So we had epidemiologists and data analysts and social scientists helping to guide the intervention. We had to manage conflicts against this room, and believe me, the conflicts were enormous where the academic medical centers didn't want this Hopkins guy coming in. The ID doc said, what's this anesthesiologist critical care guy doing? This is my problem. We're solving this. We don't need a critical care doc. So there's a lot of influencing and change management. And most of our time was spent on getting people aligned towards this common goal. And we did this really by fostering this sense of community, by tapping in their wisdom, by listening to them, and by aligning them towards this common goal. And we also had to find this key balance of hard and soft tactics. Let me give you what I mean. I mentioned how many quality improvement projects have very poor data collection. Well, when we started in Michigan, our first 2 months, we had 60% missing data. I don't have to tell any of you. I can't give that woman's mother, that little girl's mother, an answer with 60% missing data. So I called the head of the Michigan Hospital Association and said, we have to do something about this. This is just really not acceptable. That let's set up a call with all the hospital CEOs, and where I would like to tell them that if they don't submit data, less than 5% missing data, they're going to be kicked out of this program. He said, my God, Peter, we can't do that. This is volunteer. These are my members. I can't do that. I said, yeah, I know, but we have a moral obligation to the citizens of your state to see if care is better. You can't do that with 60% missing data. Yeah, but Peter, that's not how quality improvement's done. It's just everybody try and we see what we can do. I said, well, I understand that's how it's done. I ask you, though, what are you going to say to this little girl's mother when she asks you, is care safer? Because you can't give her an answer. He said, okay, I'll do it with you. So we went on there. He said, I know you want to make care safer, but you got to be more accountable for the data. So you have 2 months. If you're over 5% missing data, you keep doing the project, but don't waste our time. Don't waste your time. We want people who are committed and are going to be willing to be accountable. Now, nobody dropped out. We ended up with like 4% missing data, and it really changed the whole field of quality improvement to say, yes, you could do it with robust data collection, but believe me, it was scary. It was really scary. Another relatively hard tactic, that soap chlorhexidine cuts infections by half. And when we looked, half of the hospitals, 80% of the hospitals didn't have it in their central line kits. So it was hard for the doctors to do it. And the doctors and the nurses were complaining that they don't know how to purchase supplies in a hospital, so it was hard for them. So I had a dinner meeting with all the Michigan CEOs one night. They were at a retreat. And it was very clear they all cared deeply about safety. They all knew it was a problem, but they didn't know what they could do to help it, and they were afraid to say so because you don't get to be CEO without having the answers. So I said, okay, well, how about this? What if every month I send you a little tip confidentially? You can choose to do it or not. You could look good. Simple things that you could show support for. They said, oh, Peter, we'd love that. Absolutely. So I said, okay, one thing you can start with is there's this soap called chlorhexidine. Costs the same as betadine, but it's 50% more effective. 80% of you don't have it in your kits. Why don't you commit to go change your purchasing and get it in your kits? And I'm going to email you in a month to see if you actually did it. Great, Peter. Month later, whole state has chlorhexidine. And that may have been one of the main drivers because, again, we made it easy to comply. But it was this balance of hard and soft tactics that we had to use. So now we're really fortunate to say, how do we expand this both within Johns Hopkins Medicine and then use Johns Hopkins Medicine and sharing it with the world? And we're fortunate enough to have a donor, the former chair of the Johns Hopkins Medicine trustee, Mike Armstrong, to create this institute, an institute that's bringing the best of our researchers across the university together to really start to work together to tackle these problems. So our goal is bold. Our goal is to continuously work to improve clinical and patient-reported outcomes and enhance value, because I don't have to tell you the expenditures on healthcare are crowding out other investments in K-12 education, and we really can't tolerate this anymore. As a matter of fact, there was this moving New York Times op-ed piece last week where a mother was arrested because she used her divorced husband's name in selecting a school because her school in her area was a failure factory. They had incredibly high failure rate, and she wanted to give her kids a chance, right? And it's because of these investments in healthcare, what many would say too high investments, that we're crowding out other investments. And we really have to be mindful, again, if we're going to be good stewards of these resources. And there's enormous opportunity. The framework that we're using for this Armstrong Institute, we're really excited about because, one, we're really trying to make the values of Johns Hopkins Medicine visible and palpable to people. One of the things we're actually launching next week, is the equivalent of StoryCorps. Many of you may know StoryCorps and NPR. So our organization is just infused with science. But when I ask residents or fellows or faculty, tell me about a really moving story for you, none of them tell me how I tied knots tight, or I stuck a tube in the right place, or I got the right diagnosis. They tell relationship stories, right? They tell moving stories about somehow they touched a patient, and we haven't rekindled that. So we're working with our corporate communications to do the equivalent of StoryCorps, where faculty and patients or staff are telling stories of patient and family-centered care. And we'll be sending these out broadcast across our email across Johns Hopkins Medicine. I suspect it'll really go viral because the ones that we've sampled are just really moving. We really need to invest in building capacity. The reality is we don't have either the infrastructure or the skills of people to lead this at a deep level. Most of our medical students don't have the appropriate training in systems and human factors engineer and epidemiology. We're starting it, but what we realized is there's no free lunch. This takes deep, deep science to guide us, and we're working on those training programs. And just like we have investments in financial infrastructure where departments and units have leaders of finance who report centrally to the CFO and to the department chair like they used to report to Provost Minor, there's no equivalent people in safety to be accountable to both the department and to the Johns Hopkins Medicine, and we're working to create that. We're making a lot of progress in advancing the science. We're working with folks like Greg Hager in engineering and our public health colleagues and nursing colleagues, I hope soon the business colleagues in arts and sciences, to really say, how do we erase those lines within medicine and bring the best science? Because I believe deeply that the breakthroughs in healthcare in the next century aren't going to come from being reductionist and going within one discipline. They're going to come from the intersections of disciplines, right? And we need to create that mixing bowl that we allow those intersections to occur in a much more robust way than they have. We're obviously putting a lot of programs in, but importantly, we're really trying to create this accountability. Because what we realized is that the challenges that we face today aren't going to be solved by an institute. What we're going to need is every one of the workers at Johns Hopkins, right? From the transport people to the nurses' aides, to the nurses, to the doctors, innovating and improving and equipping them to do this, right? I heard this great story, an interview by Harry Belafonte to talk about that power, where he was asked about his early career, and he said, I didn't start as a singer or a dancer. I started as a janitor's assistant. And he said, and it wasn't an artistic job, but I did it artistically, Right? I used to dance down the hall pushing that broom, right? And we need every one of our workers in this organization to work artistically, right? Because the challenge before us are too large to think the provost or the deans are going to solve it or my institute's going to solve it. It has to come from the really innovation from that ground truth. And then we're sharing with each other. Margaret Mead, the great anthropologist, has this great quote that says, "Never doubt that a small group of people can change the world. Indeed, it is the only thing that ever has." And if I think about our work and how we're going to provide Sorrel King an answer and what made it go viral, yes, there's a lot of technical factors, but fundamentally what it boiled down to was if those doctors really believed they can do this. Because if they did, they're more than smart enough. They'll figure out how to make it work. But that voice in their head either said, "I'm not sure I'm capable of. Right? I'm not sure I could take on these doctors." Or, "Oh, these infections are just inevitable." Right? And to share with you or end on this power of belief, I want to remind you of the story of the 4-minute mile. Now, some of you may be aware of this story. That record stood for 2,000 years. Indeed, it was the longest running record of all time. 2,000 years. And the leading physicians at the time, including physicians at Johns Hopkins, said it is physiologically impossible to break the 4-minute mile. That literally senior physicians said, "You will die. You can't deliver oxygen to your muscles that fast. Our bone structure can't do it." Until Roger Bannister, a medical student, in 1956 broke the 4-minute mile. And many of you may have known that there's popular movies about it. What you may not know is the second part of the story. The year after this 2,000-year-old record stood, 2,000 years Roger Bannister broke it, 12 more people broke it. The year after that, 156 people broke it. And now high school kids in many states are at that level, right? I mean, it's routinely broken. So I ask you to reflect on what happened in 1956. And it could be like my kids tell me, well, they all got new sneakers and they could run faster, right? I don't think so. It could be like what's going on in baseball, that there were steroids or blood doping, but it doesn't appear like there's anything going on then. Or it could be that we evolved. Evolution just happened. But all of you as scientists know 2 years is way too short for evolution to happen. No, I think the only thing that happened is they believed. You see, prior to being bound by this mental model that it wasn't possible, indeed it was self-fulfilling. It wasn't possible until Roger Bannister freed up that potential to say any one of you can do it and allowed so many others now to get to unheard of performance. And I think that's what we're starting to do with Johns Hopkins Medicine with patient safety. Nobody thought this degree of performance was possible. And we hope by doing this, we're freeing up the potential to really reduce that third leading cause of death. And most importantly, give this mother an answer to her question that I believe deeply she deserves. So I thank you, and I'm happy to take questions.
Okay, we have time for a few questions. Great. Thank you.
That was a wonderful talk.
Thank you.
I was curious, so one of the things you mentioned briefly was this notion that safety saves money, which I think is another, when people talk about safety, people think safety costs money.
Right.
I'm wondering if you could speak a little bit about that.
Yeah, that's a great question, Greg. And I think there's a bit of a chicken and an egg. And let me just say something. I think healthcare has underinvested in safety infrastructure, in things like systems and integration, or even within departments, funding a physician time to be the safety leader on a unit or a department. So there is some cost. But what we've seen is that that cost pays back an ROI in multiples. So when we studied the impact in Michigan, and again, it's one of the few robust cost-benefit analysis that we did with our economist, Hugh Waters, who he has subsequently left Bloomberg, but was at Bloomberg. We showed there's enormous cost saving. I mean, literally the investment ROI on this was about 20 to 1. I mean, it's absolutely no-brainer. The challenge is hospitals say our margins are so low, I don't have any money to put up, and so there's this chicken and the egg, which it's funny. I was just meeting with the Hopkins CEO or CFO to say to create a robust infrastructure, kind of like the stuff we're talking about, would be 0.8% of our revenue. I mean, so we have a $1.8 billion revenue, so it's a lot of money. It's $8 to $10 million, but I guarantee you we'll return more than 0.8% on that, because the estimates are 30% of healthcare are waste. And if you look at what costs money, complications double or triple the cost. But in our area, where we collaborate on some looking at systems integration, The Economist, indeed, there was a great report by David Cutler that said healthcare is the only industry in which productivity is completely flat. I mean, it's frankly appalling that every other industry. And you're saying, how could that be? You're so technologically advanced. And I think the main reason why productivity has been flat is that we've built boxes, but the boxes don't talk to each other, right? So they all made silos. And I think systems integration is the main reason why we're not making productivity, because the magic isn't in an EHR, right? Matter of fact, EHR probably hurts my productivity. It's pulling all this other data so I could have a clear display of risks and knowledge so I could work on that. And healthcare hasn't done that yet, and I hope that's something we do together.
We have microphones. Next.
Dr. Pronovost, very inspiring. When you started your project with the central line infections and showed that kind of improvement, and then you started now a second phase looking at essentially another unit.
Right.
Didn't these kinds of things go viral within the enterprise? I'm sort of surprised that you're still working within the silos. You would expect people will look at that and say, I can do that too.
Yeah, so I'll give you, this is a perfect example of this tension between solving puzzles and solving problems. So many people, despite being published in the New England Journal, which for those in healthcare, it's the kind of, it's the equivalent of Science or the top chair, I don't believe it, Peter. I said, what do you mean you don't believe it? It's 103 hospitals, right? Here's the data, 5% missing data. You didn't do a randomized trial. And, the real story is I tried doing a randomized trial. We were going to do a cluster randomized to getting it early or late so everybody would do it. And because we had shown it worked at Hopkins, the Michigan hospitals revolted. It said, we don't want to be randomized to the control. People are dying. We all want to get the intervention early on. And so it was either they weren't going to do it or I had to do a time series data. And I said, okay, well, I'd rather put something in. So there was some pushback to say, well, you didn't do a randomized trial. Interestingly, it's being published now. We subsequently, to overcome that criticism, did a cluster randomized trial in a large health system that had 50 hospitals that Jill Marsteller and Bloomberg led, and showed the same results. So I think, I'm not sure why it didn't take. I think the results were so impressive that people didn't believe them. It was almost too good to be true. It was too simple. Like, what do you mean? You give me this piece of paper. Culture's a sticky thing.
I'm Han Ho. I'm a fellow of child and adolescent psychiatry over the hospital. So my question is, when we talk about improvement, like outcome, safety, looks like we focus quite a bit on for example, the administrator level, the healthcare providers level, probably because it's easier to motivate them by penalizing them, for example, yanking their license or reducing payment. I guess looks like, though, we don't usually have an effective way to get one of the major participants, which are the patients and the recipients of the care, to get involved, because obviously we cannot penalize them. Right. We can only reward them by, what you I think mentioned, like making it more personalized medicine, which, however, unfortunately is relatively more expensive. Right. So I was wondering whether you have any insight to get also this group of important player to get involved, but in a more cost-effective or overall effective way?
Yeah, so that's a great point. And let me just go through. If you look at any industry, right, I mean, all of this quality involves behavior change. And there's really, in my simplistic view, and the business or sociologist can correct me, there's 4 levers you can change behavior with in any industry. Right? You could regulate it. You can create economic incentives. You can use management tools or hierarchies, thou shalt, or you can use what's called networked approaches of communities to tap, like you said, get involved in the patients. And what there's overwhelming data is, though all are needed and all have risks, amongst professional groups, so like in medicine, those first 3 are highly ineffective and often wrong. I mean, the Joint Commission is never going to make care as great as it could be, right? It'll be the bottom of quality. It's never going to be great care. And we haven't done enough of these networked approaches, like I call them, these clinical communities, where it's the clinicians and patients. So we had patients involved in this in most of the ICUs, and these hospitals had their own Josie story to make it real for them. We're doing some stuff, for example, we're doing the same bloodstream infections in outpatient dialysis patients, and much of their care is home. So literally we're with our engineers and the human factors folks modeling out how, with these patients, what do you do when you go home? How do you take care of this catheter? And what are the risks? And they're every bit as with us at the table. So I think that's a huge untapped resource that we need to bring them in. And not only is it cost effective, I mean, I don't think these other approaches are going to work. Telling you what to do as a doc as if somebody else knows the answer is naive. I mean, you're professionals in that I think you're going to get a better solution. We do need accountability mechanisms because the tribe hasn't been so accountable in medicine, and we need to be more accountable. And I hope clinicians step up and really take a leadership role in this.
Thank you. This is very inspiring, as usual. I think the question that I have is a broader question, which is that, I mean, clearly there's really a huge success story here, as you've told it. But if we look at the global picture of something like, what is the picture really of health, of disease burdens, and what are leading causes of mortality in the world.
Right.
I mean, there's something like 2 very, very important factors that are very clear. One, that there are parts of the world in which for the first time adult mortality has gone up. Right? And it seems to me that, that's one. And the second is that if we actually look at health inequities, if we look at health of women, something like maternal mortality is still a leading cause of death in a whole lot of areas. And this is where at least 2 factors are very important. One is their very powerful externalities, which health is particularly very important to think of, so that there become questions really of, are you going to be investing in something like female literacy, or are you going to be investing in something like highly functioning hospitals in those parts of the world? And I wonder whether in some ways, it's unfair to say to someone who's been so successful in defining a particular cause and attending to it within very well-defined conditions. But I wonder whether you have thoughts about the fact that when we move out of these very well-defined conditions of a patient already in the hospital and think about leading causes of death in the world today, whether you have thoughts about
No, absolutely. Matter of fact, we were exploring and are looking for funding to do something on maternal mortality. And let me tell you what I think we bring novel. That first slide, or let me go back to it, about the basic feed-forward research, right? And that's typically how we go. So in engineering, field forward. What we did in this work was do feedback. We started with the end game and then said, what do I know and how could I reduce? We'll take maternal mortality example. When I look about the difference between what we did, and admittedly it's simpler, maternal mortality is high, what I noticed, though, is we're still in silos. So the economist at the World Bank will take an economics approach, right? Or the doctors will take a healthcare approach. What I haven't seen was this more comprehensive approach to say, okay, yes, there's going to be some public policies, and literacy might be a piece, access to health services might be a piece, and to try to package a comprehensive program that doesn't pull on one lever, pulls on all the levers that are known. Now, my research colleagues cringe and say, but you're not going to know what lever really caused the improvement, right? Was it the literacy, or was it, and as again, I'm more in the Popper school. If I want to solve problems, I say, unless that lever is really risky or really costly, I don't really care, because a lot of people are dying every year, and I want to solve the problem. And to me, I think we've been too focused on, could I make an inference about this one lever? And this is complicated stuff. Any one of these levers will have a relatively small risk reduction. I think it's only when you package with economic incentives and good, the biologic science and, access or health literacy, that we might be able to really move the needle. But that's a mindset that most academics cringe at, right? Because they say, but then you won't get published because you can't tell me what independent cause was it. And I think, again, Karl Popper's words hang in my mind that I think, but maybe we also start working on problems and not just puzzles.
Dr. Provost, thank you very much for the inspiring speech. My question is about the ability of doctors. It's more from a doctor and a management perspective. You're talking about changing the culture from in the doctor-nurse relationship, but what about the doctor-management relationship? And in the point of, did you get any pushback from doctors in the U.S. saying, listen, our management wants us to see a certain volume, and we have to rush between these patients. We don't have enough time. Or are there any maybe comparison studies to abroad where maybe the volume isn't as much of an issue? I'm kind of curious what your thoughts are on that perspective.
Yeah, so I can show you the scars on my back. We got a lot of pushback. Less about volume, but more autonomy. I mean, autonomy is, and medicine has benefited from an autonomy, right? That's how we get amazing amount of innovation. One of the things that I struggle with the most, it's separating what I call mindless versus mindful innovation. So mindful innovation is I have a hypothesis or a hunch of why this patient deserves something different, right? And some of the genetic medicine or individualized medicine is this phenotype needs this other dose. That needs to be encouraged, and we need to create incentives to do that. But so much variation in medicine is mindless. It's I'm doing it because I have power, right? Because I'm the chair or because I want to. No hunch, no hypothesis. And that, I think, is we have to create much greater accountability mechanisms to say, no, that really doesn't exist. And medicine has very poor accountability, as a matter of fact. It's a lot of individual entrepreneurs. And the challenge is, if we have a health system that's geared around caring for individual patients, but quality and safety involves managing a population of patients. But there's no physician management infrastructure to manage that population, right? So it's no wonder we haven't made progress. We haven't created the building blocks like you would in any other industry to say, well, who's the doc responsible for either this group of patients or this care area to say, yes, you're going to be accountable for all the care that's done. We're starting to create that, but it really hasn't. To get your idea up, I should have mentioned this in my talk. It's actually interesting. We were submitting our paper to New England Journal this morning. So we put this program in 85% of the Spanish hospitals, 60% reduction in infections. In 88% of the UK hospitals, 65% reduction in infection. In about 15 Peru hospitals, so very resource constraint, would it work? They had like a 55% reduction in infections. Now, they all varied a little bit. I mean, it wasn't the same intervention. They had different cultures. Spanish culture was much more hierarchical, doctor and nurse, so that was a really hard nut to crack. But the reality is I think these approaches are not just healthcare. I think we really have insights into a broader change package that could be broadly applied.
Hey, maybe one more question, because we do have a reception waiting upstairs for us. So. One more question.
How you doing? That was a great speech. I think the work you've been doing is incredible.
Thank you.
You're mentioning with this slide here, the advancement of the philosophy and the teaching as well with regards to medicine as technology advances and stuff. As someone who wishes to pursue a career in medicine and public health and broaden that, if you go back in time, stuff you know now and apply that, then, do you have any advice, or what would you wish you knew then that you know now?
Yes, so that's a great question. And medical education, I think, and there's many physicians in the audience, is in a bit of a conundrum. And what I say is that I think we're in an arms race, or more equivalent, a facts race. That if you look at the number of published articles, over the last decade, it's gone up exponentially. And our response has been cram more facts into our students' head, right? And I can say I'm a graduate of Hopkins Medical School, and it was one of the most unintellectual experiences of my life I've ever had. Because if my brain could function with a lot of RAM and take stuff in, sort it, and spit it out, I did well, and I could do that. But it wasn't thinking, right? And I think we're at the point where, and this is controversial, but I think it's a huge thing, is we have to accept that we're not keeping up with the facts race, and we have to start teaching theories and concepts, right? And maybe a few facts, but the facts are outdated by the time you graduate. And we haven't made that switch yet to say, okay, I'm not going to teach you every topoisomerase. You're done. But you need to know genetics. You need to know the theory. You may need to know a couple things and start teaching you how to think and solve some of these, work these issues out. And then importantly, where you can get the data when you know it. And again, it is readily available so that you can have it just like a just-in-time inventory, rather than thinking facts are going up, so you sit in your butt in a chair more hours and cram more facts into it, right? And that's, I say that humbly. I'm not an educator and a health services researcher, but I see this tension of more and more facts, cram it in. And we have these tensions because if I say, like my medical school, I spent somewhere around 900 hours looking at pathology slides, 900. Unless you're a pathologist, you will never look at pathology slides as a doctor. But I had very little, if any, training in leading change, in conflict resolution, right? In things that I do every day in breaking bad news, and that every doctor does every single day. And in part, I think it's because we haven't viewed that as a science. Nick read that quote. We haven't viewed that, well, what do you need training for that? That's just what every doctor does, right? And if you look, even in most medical schools across the country, they'll have hundreds of geneticists. I guarantee you we're the rare exception that has a human factors or systems engineer on the medical school faculty. They don't exist, right? Or a sociologist, right? Or a psychologist to teach teamwork, or an operations researcher, because we're still viewing these first two boxes as that's all that exists, and we haven't done the last box of understanding the health science delivery. So I think here at Hopkins, we're way ahead of the curve because we have these interdisciplinary groups. I mean, I meet with Greg and his team as often as I meet with the basic science team. We work really collaboratively with engineering and public health, and I think that's what it's going to take to solve some of these big problems. So I thank you, and